to the discussion on evaluation of a neck lump. A few things that I like to tell about this is that neck lump is a thing that we commonly see in our clinical practice, especially people coming to the clinics. And also, it is very important to remember that it is not a difficult thing to make a quick clinical diagnosis of a neck lump. And because of this, even at the exam, usually the neck lumps are given as a short case where you're given a brief time to take a quick focus history, do a focus examination, and make the diagnosis. So I'll be discussing this case evaluation in the style of how it's maybe done. Also, this is what we do in the clinic, and also at your the OSCE, or the short cases, the way we used to call it. So you can have a look. Now there are various type of neck lumps shown on this the photos and photographs. So this is what you how the various people come to your clinics, and some more views. But before getting on to the discussion, we just try to look at the neck anatomy, which actually is the basis to make the diagnosis. And always remember that any part of the neck, whatever the triangle, don't forget that it could be a superficial lump, superficial to the deep fascia, either a skin lump like a sebaceous cyst, or a subcutaneous like a lipoma, or maybe some midline dermoid. But now I'm going to concentrate on the deeper lumps in this part of the discussion. And one important thing is whether the relationship to the sternomastoid, whether it is anterior to it, which is the anterior triangle, or whether it's posterior, the posterior triangle. Because the anatomical structures in the anterior triangle and the posterior triangle are different, because there are certain lumps which can occur only in the anterior triangle, like your thyroid or the carotid related pathologies, and also the branchial cyst. And the posterior triangle, there are certain things which can happen only in the posterior triangle, like a cystic hygroma, or something with the subclavian artery, maybe a subclavian artery aneurysm, and also a pharyngeal pouch. So these are things that you make a diagnosis only in the posterior triangle. But lymph nodes, of course, it can occur in both triangles. If you want to go into a bit of further extension, but even if you remember this level, anterior triangle, posterior triangle, you can do a good sensible clinical diagnosis. But of course, if you go into the further divisions of the anterior triangle, the submental triangle bound by the digastric, the anterior bellies both side, and the hyoid bone. Here, of course, again I have to tell you each triangle. I'm not going to again repeat about the skin, but please remember the sebaceous cyst, lipoma, it can happen. But here the other deep ones will be the lymph nodes. The submandibular triangle bound by the anterior and posterior bellies of the digastric, and the mandible, the inferior border, your submandibular salivary gland, and again the submandibular lymph nodes. So as I said, all triangle lymph nodes are there. The carotid triangle higher up, the carotid artery related problems, the carotid body tumor, and also maybe carotid artery aneurysm, and also it could be a schwannoma coming from the vagus nerve, and also the branchial cyst, and again the lymph nodes. So carotid triangle, if it's higher up, these are things that you're going to think of. The muscular triangle, the thyroid and also the lymph nodes. Of course, the thyroid can, upper pole can extend to this part also. So with this understanding, especially remember about the anterior posterior triangle at least. But other things also will make you to make your diagnosis more refined. But anyway, we'll look at these clinical cases. Now look at these lumps. Now in the previous picture also we had a look, but now we are looking with a different sense. And all these lumps, as you see, they are in the anterior triangle. So here we are going to think of the differential diagnosis of the anterior triangle only. And some more lumps of the anterior triangle. Now look at this. They are in the posterior triangle. So we just think of the posterior triangle differential diagnosis. But again, generally to get into all the possible lumps, so with these keys, it's very easy to take the discussion on. So these are the possibilities. We'll take one by one. Goiters. And we know that in our clinical practice, goiter and the various forms of lymph node enlargement, maybe it may be about 90 to 95% of the neck lumps that we see. So as I said earlier, it's a very easy diagnosis that you have to make. Don't make it complicated, or don't get worried when you see a patient in your clinic, or especially at the exam with a neck lump. Keep to your basics. It's very easy. So goiters and various forms of lymph node enlargement, infective and malignant. Then other things which are not very common, but even though they are not common, they may come, and then of course you have to make the correct diagnosis. Maybe a branchial cyst, carotid artery problem, schwannoma, cystic hygroma, pharyngeal pouch, cervical rim. So this is back of our mind. And so we'll take case by case. So read the history. So she's a lady, 30 years, coming with a lump, and she has had this for 1 month. So as I said, now one thing is the anterior and posterior triangle demarcation will guide us to the diagnosis. Another one is, of course, at a very early stage, either confirm it as or exclude as a goiter. Then the balance is very easy. So even before you embark on further questions, you just ask the person, please swallow. And if it moves, of course you know it's the upper pole of the right lobe of the thyroid, and you just concentrate on thyroid history and examination. But if it doesn't move, then of course you have to think of non-thyroidal conditions, and it is anterior triangle. Now this lady, when we asked to swallow, it did not move. So it is not thyroid and an anterior triangle lump, and of course it's pretty high in the anterior triangle. So that also gives a clue. And it's 1 month, and of course you can ask some other couple of questions, whether it had been keeping on enlarging. Is there any pain? Have you got any fever? And then look at the differential diagnosis of anterior triangle lumps beneath the deep fascia, not a thyroid. So the commonest would be one of the lymph node enlargements, and then the balance. So we'll take one by one. So what are the brief history you're going to take? So it may be just some short inflammatory thing, but of course she says 1 month, but of course it's worthwhile asking any. If it's a shorter history about fever, sore throats, those things. And then tuberculosis, any night sweats, any low-grade fevers, any loss of appetite, weight, chest symptoms, hemoptysis or cough. But sometimes these neck tuberculous lymph nodes, they are otherwise all right. Secondary deposits. So a general inquiry. 30 years as secondary deposit is very bit unlikely, but you cannot say, it may happen. Any oral problems, dysphagia, again cough, hemoptysis we have asked, and any dyspeptic symptoms, loss of appetite, weight we have asked for TB again, lymphoma, have you got any other lymph nodes feeling, and if there's any feeling of uncomfortable or fullness in the abdomen, which because they may be having a hepatosplenomegaly. So with this type of short history, when you examine with the history, you may get some idea, you may not get, it depends. And then on examination, one of the important thing is just to see whether it's just a, even the person just has one lump which is seen by, noticed by the patient, that there may be other lumps also. So if it is multiple, there is no question. There is no question out of this diagnosis. It has to be a lymphadenopathy. The cause may be anything. But if it's multiple, it cannot be one of these. So if it's multiple, you just examine the further details of the lymph node. The consistency of it, whether it's a matted lymph nodes like tuberculosis or many multiple like a lymphoma, a very hard feeling of a secondary, so you can go on. But if it's single, so this lady, it was a single lymph node. So if it's a single lymph node, so coming back, it's the anterior triangle, not a thyroid, and it is single. And so these are the possibilities. So lymph node. So when you feel the other physical signs like the consistency, the margins, the mobility, you can find out the possible diagnosis. So lymph node, you may have a bit of a firm node, some mobility, especially in the lateral directions, and of course you have to elicit other physical signs like tenderness. And then carotid body. I mean, this here carotid pathology is quite possible because it's a carotid triangle. But so it's very simple. Keep your 2 fingers on either side of the lump and see whether there's any pulsation. So it could be a carotid body tumor and carotid aneurysm. Not a very common pathology, but of course could be. So most of the time you have a bit of a transmitted type of pulsation. It is likely to be a carotid body tumor, but a lymph node also may get some bit of a transmitted pulse, but it won't be so evident like in a carotid body tumor. Or again a bit of a firm lump, it could be a schwannoma with some restricted mobility. Now if it is cystic, if you keep your 2 fingers on the side, press in the center, get fluctuation in 2 planes. If it is cystic, of course, you are going to diagnose a branchial cyst or maybe a cold abscess. But in a cold abscess, there will be some other features like there may be features suggestive of tuberculosis. And also one point, even though branchial cyst is cystic and a cold abscess also cystic, they wouldn't be transluminant because the contents are generally, they are a bit opaque. So now this lady that presented to us came with a history, 1 month history of a lump here, and then it was slowly enlarging. There was no pain, and of course she didn't have any other significant primary symptoms. But anyway, it didn't move with swallowing, so anterior triangle. So these are the possibilities, and there was no pulsation, and it was not cystic. So we diagnosed that it's a cervical lymph node. And as I said earlier, majority of the clinical diagnosis that we make in the clinics are either thyroids or lymph nodes. So that's why I say it's not difficult. But of course, you should have an idea what type of lymph node pathology could be with your history and other things. So then, of course, so what are we going to do? So you do some basic investigations. So what in general terms, 2 very useful investigations evaluating the neck lump will be an ultrasound scan, number 1, because it will tell you whether your diagnosis lymph node is correct or if you're diagnosed a carotid body tumor, carotid aneurysm, whether it's correct, and similarly a branchial cyst. If you want further detailed imaging, of course, you may do then a contrast CT, but in a majority, ultrasound is good enough. And then FNAC, if it's a lymph node, that's your primary tool, you may do a FNAC. And it may give, say, like a secondary deposit, it may give you the answer. But in some cases, like a tuberculous lymphadenopathy or a lymphoma, it may be not diagnostic, but of course the pathologist says it's better to do a excision biopsy, and then of course you get the diagnosis. So it is not difficult, and it is a good idea. I know now these days you are not doing the clinicals because of the COVID problem, and get somebody household marker, circle in the neck, and then practice this. Take a history and then examine and ask to move it, and it's not moving, it's solving, and then make an imagination and feel the lump for each of these pathologies. First thing is a lymph node, and think that you describe, it's better you can just speak when you examine. Okay, I am feeling a lump, it's in the anterior triangle, and it is firm and some mobility in the transverse plane, and then it is firm in consistency, and then come from forwards and keep your fingers on either side and say, okay, it's not pulsatile. And also check for fluctuation. Okay, it's not cystic. So my clinical diagnosis is a lymph node. And then again, you on the same lump, you just assume, you go through the same scenario, and then you say, okay, it's pulsatile. So I think it's a carotid body tumor. It's a firm lump, and very limited mobility, and it's pulsatile. So I'll order ultrasound scan, and it shows a carotid body tumor. And to get further information, I'll do a CT angio, and here you're not going to do a FNAC, obviously. So like that, for each you practice. It's very important to remember that examining a normal person with these marks, the lumps marked or whatever, or your normal system examination, improves your clinical skill. It is not necessary to have a patient all the time. Two reasons. One thing is, this is a practice, like one day also I told, like practicing a drama or practicing a music. More you practice, your performance is going to be better. So you have this scenario building up in your mind, the pattern of thinking. So automatically when you see the lump, even without thinking, just things will fall in your mind. Okay, solving, it doesn't move, you're even just visually you will know anterior triangle, okay, these are the possibilities. So just within a minute you can make the diagnosis. More you practice, the scenario will open in your mind. So keep do this, and also you can look at these photographs and also practice. But it's always better to feel on somebody, and also you will feel the normal feeling of a person, and as you feel something different of a lump there, you quickly know it's okay, it's something different. So practice on this again. Just think of a history, 5 months history, very slow growth, no pain, unless it's got a history of infection, and at the beginning you just ask to swallow, and not swallowing, you move on with the balance of the history. But if it's swallowing, you get a thyroid history, so it didn't move. Then so possibilities. So it's anterior triangle, lymph node, carotid body tumor, carotid aneurysm, branchial cyst. So take a quick history of things I mentioned earlier, like history of Cox or whatever. And for this, everything will be negative. And you examine, you feel a lump in the anterior triangle, and which is cystic. And then you wonder if it is a branchial cyst by the typical site of the lump, and your ultrasound will confirm the diagnosis. But at the exam, of course, if you have a bit of a doubt, you can give a differential diagnosis. Okay, it may be a lymph node, but of course this site is common for a branchial cyst, and I think it's cystic, could be a branchial cyst. There's no harm, because we check your confidence on these. But if it's not pulsatile, you are not going to say it's a carotid body tumor. So it's something like that. Be sensible and confident, and if you keep on examining and practicing this, confidence will just come by practice. Then another lump, another case history. Take a second, look at the history, pause the video, and then think of a pattern. How will you go on this lump of the history you are going to take, an examination, and how to come to the diagnosis. So pause the video, wait for a while, and then restart and think whether you have got this pattern. So again, a lump of 2 months duration, and clearly you see that it's in the posterior triangle, but there's no harm. Ask to swallow, because sometimes of course here it cannot be, if it's a large, quite obviously coming to the posterior triangle. You will see it here also. So here I don't think there's much sense, but as a habit neck lump, no harm asking to move it swallowing. And then, so it's not moving swallowing, so it is posterior triangle. So what are the possibilities? And again, if it's multiple, it has to be a lymph node. So here it was not multiple, single, so it could be any of these. And you have taken some focus history, especially regarding lymphadenopathy like tuberculosis, secondary deposits, and all that. And you examine. And this patient, it was a firm lump, some mobility, there was no tenderness. And then you straight away, without any problem, you say it's a lymph node. And then do your scan, do your FNAC, if necessary, do the excision biopsy. And other investigation, of course, I'm not going to discuss all, but of course, a blood count may be useful. And some cases a chest X-ray may be useful, and also if it's you think it's a secondary deposit, but first if it's secondary deposit, first you confirm with your pregnancy. If it comes as adenocarcinoma, then of course you have to screen for the primary. Anyway, so if it's cystic, then it is a cystic hygroma or lymphatic cyst, but this position is pretty unusual for a cystic hygroma. It is a little more on the subclavian fossa. And subclavian fossa, now this again unlike to be a subclavian aneurysm just by the look I'm telling, but always feel with the sparsitile, because it's more again subclavian aneurysm. Usually, most of the time they are related to a cervical rib, so it will be there. But here there's no doubt. So very easy walk through diagnosis to a lymph node enlargement, and just how cystic hygromas look. They can be very sort of prominent lumps or sort of a bit of a diffuse enlargement, and they are in the posterior triangle. And as I said, it's more occupied the supraclavicular fossa, and it's there definitely cystic and brilliant transinguinal. So it's not at all difficult to make the diagnosis. If it is a bit of a confined small lump, of course you can even say a lymphocele. There's no problem, because it's the pathology there is some of a lymphatic system, bit of a larger complex one. And then, yeah, this I'll get it a bit enlarged. Practice on this also. Same form. This is more on a supraclavicular fossa. So it's a posterior triangle. So think multiple, it should be lymph node. It's single, again could be a lymph node, could be a lymphocele, and also subclavian aneurysm possible, but to enlarge to this extent, of course, bit not very common though. But of course, examination will confirm. Firm, it's a lymph node. Cystic, it's a lymphatic cyst. If it's pulsatile, or could you just say without any problem, it's a subclavian aneurysm. Look at this one. Again, a lump in the posterior triangle, more in the supraclavicular fossa. So possibilities by look, could be a lymph node. I mean, just working the diagnosis. Is it subclavian aneurysm, a small lymphatic cyst? But of course, he had a lot of cachectic symptoms, and also loss of appetite, weight, and then feeling. Again, posterior triangle, it was a hard lump and very limited mobility. So it is lymphatic cyst completely out. So it has to be a lymph node, and hard lymph node. Secondary ultrasound confirmed FNAC was adenocarcinoma, and he had a primary, so we had to do an endoscopy, upper GI endoscopy. There was a gastric carcinoma. Now, when you examine, posterior triangle hard lump, can it be a cervical rib? Of course possible, but usually cervical rib, you can't see a sort of discrete lump like that. And also their presentation, why the patient come, of course sometimes they may feel it, but usually the cervical ribs are not very well palpable. They will come with their symptoms on the upper lip, with their nerve root pain and with the numbness and whatever. And then those cases, the person coming with neurological symptoms of the upper limb, always you have to exclude a cervical rib. And you have to feel, you may feel it, but a significant number with symptomatic cervical rib, sometimes you may not feel it. It's important to remember that. So this your cervical rib and pharyngeal pouch. It's a very rare condition, and uh, most of the time they come with the GI symptoms of it, and the contrast studies will actually confirm. First, you may do endoscopy, and you see this narrowing, and of course you can't see a mucosal lesion, so you do a contrast study, you will see this. Only in bit advanced cases, a person may actually complain of a lump. So when you get a posterior triangle lump, unless you are sure of the symptoms, don't embark on this rare diagnosis. But anyway, just for interest, pharyngeal pouch, what are the symptoms? Obviously, when you look at that, you will understand that they will have dysphagia, because this pouch is compressing on the normal esophagus. It's a endometrial representation, and also the food collected will always regurgitate. So they will have a lot of regurgitation. So dysphagia, regurgitation, you may think, okay, the elderly man with a carcinoma esophagus. And also they have a lot of halitosis, and also by spillage respiratory symptoms, more or less like a carcinoma esophagus symptoms, but the history generally more prolonged than a carcinoma esophagus. And also late cases, the person may say, I have a fullness in the posterior triangle, and when I press, it gets reduced with some gurgling sounds. And if that is there, when you press also, you will this, that it gets emptying with some noisy, like reducing a hernia. This is a very rare condition, but if the symptoms are definitive and uh, you feel the thing reducing gurgling sounds, of course you can make the diagnosis. And of course your workup will be first the upper GI endoscopy and then the contrast studies. And just after the discussion, you go through this diagram, because it further divides the anterior and posterior triangle into various levels for the lymph nodes. There's no harm actually with time remembering this, because when a lymph node enlarge in one of these stations, you know the possible draining area, because like here uh, you think more of, like say, upper GI malignancy is coming, the virtuous node, and here you are not going to, if this isolated node here, you are going to think of other draining sites. So it's actually a nice diagram to learn the various levels. I'll not discuss this because you can just read it. So to come back to the neck lump, it's a common problem, easy to diagnose, and you are generally, you can make the diagnosis in a short time in the clinic, and also at the exam they are given as a short case. So the important steps in the diagnosis is to just, as the patient sits, tell the lump, you can visualize whether it's an anterior triangle or posterior. Of course, you can feel the landmarks for the sternomastoid, uh, the mastoid process, and the sternum and the clavicle. But even generally, you can just say, so anterior triangle or posterior triangle. And just talking to the patient, first you ask to swallow, thyroid or non-thyroid. If it's thyroid, your history and examination totally related to thyroid examination, which we'll discuss on another day. But if it's not thyroid, anterior triangle, we discuss the differential diagnosis. Posterior triangle, we discuss the differential diagnosis, and just physical examination will tell you the diagnosis. And the basic initial investigations, very useful ones, are ultrasound and FNA. But of course, you can go into other investigations as necessary. And also, if you remember the various levels, it will be easy. And also another thing, of course, in this submandibular triangle, please remember the submandibular salivary gland as well. And a parotid may come into this area, but of course it's not difficult to distinguish a parotid lump. It is in the parotid area. But of course, in this region, you can have a differential diagnosis, parotid lump and a lymph